Hello everyone and welcome to tonight's update. We're going to talk specifically around Aboriginal health. We're going to have a panel tonight consisting of Dr. Kat Taylor, Dr. Kathryn Todd. Our executive John Bailey is going to give an update, and then we're going to have a mob come on and talk about various issues from across the region. My name's Tony Manton. I work at the PHN. I'm the ITC Services Coordinator here. Firstly, I'd like to acknowledge the traditional owners on the lands on which we're all coming from and meeting here today, and pay my respects to elders past, present and emerging, and also my brothers and sisters that are live tonight. Who am I going to introduce now? Kat Taylor is going to come and give her presentation.
Thanks, Tony. Hi, everybody. You're in for an absolute treat tonight. So we thought we'd keep it quite short and simple on the epidemiology side of things. So Todd, we might just flick to the first slide. We're not going to go into too many details about coronavirus. We've done a series of webinars which many people... Oh, there's a clicker. Oh, yes. Okay, I can do this myself. So we're not going to go into too much detail about pathophysiology or infectious disease or anything like that, but just have a quick look at the numbers in Hunter New England Health, and then Kathryn Todd from the Central Coast Public Health Unit will have a bit of a look at the Central Coast statistics, and then we'll pass straight over to the wonderful mob that we have here. So most of you are pretty familiar with this terminology of flattening the curve now. And encouragingly, things are looking quite good in Australia by contrast with the rather dire global picture. So you can see this is national data that was presented by the Chief Medical Officer. The number of new cases happening each day Australia-wide are reducing. We're seeing that on a national level, a state level, and also a district level. And so that total number of cases or cumulative cases are flattening. And so we think that this is a result of the border measures that were implemented first, followed by the social distancing measures. And so as those steps have tightened, we've seen an according reduction in cases, new cases. Just a little bit of a side point on other unintended consequences of social distancing. So this is the great work that everybody's doing in communities of staying home, not going out other than for essential reasons, staying away from each other and staying away if sick. We can see that this is really having a dramatic impact, not just on COVID cases, but also on things like community reported rates of influenza-like illness. So this is pretty exciting data. This is based on our flu tracking database, which is people in the community that sign up to do a weekly survey, which is done during flu seasons. We started it a little bit earlier this year with all of the coronavirus things. It's a couple of simple questions that people answer each week, and there's I think 40,000 or so participants across Australia and New Zealand now. But this is just our Hunter New England data, and very excitingly, influenza-like illness, so fever and cough in the community, is at an all-time low. It's at 0.27% prevalence among people in the community. And I understand that this effect is even more marked in people who identify as Aboriginal and Torres Strait Islander, which is a huge testament to the work that people are doing in staying home and staying away from others. So these are just some of those measures that I mentioned earlier and how they relate to what's been happening with the clinical picture. This is what we've presented in previous presentations as an epidemic curve. So essentially, the bars represent the total number of cases that are notified on a particular day. And you can see that there was, as things started to take off around the beginning of March, then on the 15th of March, all overseas arrivals were required to self-isolate for 14 days. And then this was subsequently followed during mid-March with restrictions on public gatherings of more than 500. And then sort of around the 28th of March, these quite stringent measures were brought in, mandatory 14-day quarantines for hotel travellers, and also for restricting people quite significantly in public. And you can see the dramatic effect that that's really had in Hunter New England. This is just a quick look at our numbers in Hunter New England, broken down by where we think the person has acquired their disease. And you can see by and large the great majority of people picked up their infection overseas. And so that's represented by the blue bars. So you can see the majority of cases were overseas acquired. That's followed by locally acquired people who had known contact with a confirmed case. So these are people that share a household with people who've come back from overseas, and unfortunately, you would expect a degree of household transmission in that setting. So there's been some close contacts. Then there have also been a small number of people who have contracted their infection locally. So they haven't had any history of travel, they haven't had any known contact with people confirmed to have COVID-19. And we can see that there have been a few of those scattered throughout, and certainly, over the past week or so, we've had very few new cases notified, but the couple of cases that we have had have been of unknown source. So we think that, COVID-19 is probably still out there to a very small extent in the community in small pockets of limited transmission. Just a quick overview of the demographics. So 271 cases total in Hunter New England Local Health District. And reassuringly, not a lot of those, so currently we have, I think, 7 that are hospitalised. We have unfortunately had 4 people who have died out of those. But you can see by and large, most people have been in the age group sort of 30 to 70. And this may reflect kind of the cruise ship. So unfortunately, we had something like 70 cases associated with the Ruby Princess cruise. So cruising and overseas travel has accounted for the great majority of our cases. And also to note, we've had very few cases in people aged under 10. In terms of people who identify as Aboriginal or Torres Strait Islander, there have been 10 cases to date in Hunter New England Health, representing 3.7% of the total cases. And reassuringly, those people haven't had very close ties to community, they haven't been necessarily part of remote communities, and they haven't been related to each other. So most of those have been related to overseas travel or contact with other known cases. Just a quick overview of some more epidemiology. We've spoken about the source. So as I said, overseas, 3/4 of the cases, contact with a confirmed case, 15%, and no contact identified, around 10%. And with the recent lull in cases, we've been able to really invest heavily in doing some additional contact tracing and trying to understand that story of where those locally acquired cases may have come from. I'll just briefly present this one. So this data is available on the New South Wales Health website, but I've just pulled out the local government area data relevant to Hunter New England. And this is essentially what is helping to guide our emphasis on testing in certain, they're sometimes called hotspots, but this data is helping to guide where we're pushing for testing. We don't report numbers smaller than 5 because of possible issues of identifiability. But essentially, these are all of the local government areas that have had cases that have not had a known source. Newcastle, because that's obviously sort of a large metropolitan area. Lake Macquarie, that was the stimulus for us pushing for testing in the Lake Macquarie area and really stepping up the Belmont drive-through clinic. We fortunately haven't seen really any cases from that area in the past 2 weeks, so we've taken that off as a hotspot. But there's, I guess, renewed focus in the Upper Hunter and particularly Tamworth and Moree for increasing screening and testing. Just very briefly, I know this is a busy slide, but this is some really interesting work that's come out of the Belmont drive-through clinic. So people that were presenting through that COVID testing clinic were being administered a short survey to find out what their symptoms were. And then we were comparing people's symptoms of people who had not tested positive to COVID with people who had tested positive. So we know what some of the symptoms have been for confirmed cases, but we just wanted to get that comparison of, are there any symptoms that can really differentiate between people that have COVID and people that don't? And so this is very preliminary data with thanks to our planning team. But we just wanted to bring your attention to that, for example, arthralgia, so this is aching joints, seem to be a lot more common. So 46% of people who tested positive for COVID had joint pain versus versus 25% of people who tested negative. So that's an interesting comparison in terms of some of the things that might differentiate COVID from not COVID. Also small numbers, but people with quite bad respiratory symptoms or pneumonia, they also were more likely to test positive to COVID. So that's just a bit of an interesting overview of that. In terms of testing data, we've got a really great testing rate in Australia, although there has been a bit of a shortage of swabs and we've been working our way through lab issues. Certainly there's huge amounts of testing being done. We're probably world leaders in terms of the proportion of cases that are being found in Australia. So that's really reassuring data. You can see this is Hunter New England data. At the peak, we were doing around 4,500 tests in a week. And so there's been great capacity there. Reassuringly from this graph, the line actually represents the proportion of those tests that were positive. And you can see that even though, you know, the number of tests has remained high, the percentage that are positive has actually gone down. So that's really reassuring that, you know, we're expanding the net, we're doing more tests, but actually the proportion positive is decreasing. Just a little snapshot of how we're performing in terms of testing. So the state average of tests per 1,000 people is around 15. So around 15 tests per every 1,000 people in the population is happening across New South Wales. Newcastle is above that, but there's a number of local government areas that are below that. And you can see sort of towards the bottom there, you know, Upper Hunter Shire, Moree Plains, Muswellbrook. Obviously they're small regions, but these were areas that we really wanted to focus in on and boost those testing numbers so that they were looking a little bit more like the rest of the state. And so you might have seen some publicity recently about really trying to push testing in those areas, and I think John and others will talk about the things that have been set up to enhance testing for those areas. Okay, I said I'd be quick, so I'll just go through this very quickly. Again, we're not recommending that people with no symptoms get tested, but the testing criteria are changing quite frequently. The most recent update, I believe, was on the 17th of April, and essentially it's trying to condense it down into anybody with fever more than 38 degrees or a history of fever or acute respiratory symptoms. So this is cough, shortness of breath, sore throat. And they need to also meet epidemiological criteria, which is defined as they've had known close contact with a person with COVID-19, they've travelled recently, they're in a high-risk setting, so you know, that includes people living in Aboriginal remote communities, healthcare workers, and then there's been some New South Wales specific testing criteria, which are living in communities with local transmission, and that's why we're now really focusing on those local hotspots. People who self-identify as Aboriginal, so really trying to ramp up and find any possible cases in the Aboriginal population. Anybody who's referred by a GP or public health unit. So for the GPs out there online, you know, please feel confident that when you refer people for testing that they will be tested. And also anyone where there's clinical suspicion that they have COVID-19. Just one other update, which has been causing a little bit of work and grief recently, is about the release from isolation criteria. So this is something which the Public Health Unit is happy to keep carriage of because it is a pretty complex and evolving space. But just to give you a heads up on what the guidelines are that we're currently following, for people who had a fairly mild illness and they didn't need to go to hospital, the criteria are they need to be at least 10 days past their first symptom, and that they need to have had no acute symptoms for the last 3 days or 72 hours. And there's no swabbing needed for those people. So we're running into a whole lot of interesting issues about, you know, trying to give people clearance swabs. But so for, by and large, most people in the community, it's just 10 days after your onset and symptom-free for 3 days. If people were hospitalised, had a bit more of a severe illness, they may have been released during their hospital stay using clearance swabs. But if they've just been discharged but considered still infectious, then it's another 10 days after they've been discharged from hospital, and also they need to have had no symptoms for at least 72 hours. It's a little bit different for healthcare workers. So for healthcare workers, it's a bit of a shorter time to when you can start trying to clear them, but we do require 2 clearance swabs for people who work in healthcare or aged care. As I said before, the Public Health Unit in Hunter, New England will release and also provide clearance certificates for confirmed cases going back into community. And just again to stress that clearance swabs are not required for anyone to be released other than for people who work in a healthcare or aged care facility to go back to work. Right, so that's it from me. I'm going to cross now to Kathryn on the Central Coast, Dr. Kathryn Todd, to give us a bit of an update on the situation in the Central Coast. Thank you.
Thanks, Kat. So I believe I've had a slight technical difficulty with my slides, so we're going to try and keep broadcasting the slides from you, Kat, and I will just speak to them. So we'll see if that's possible. Let's see. That's great. Thank you. So this is just a little epi update of Central Coast to add on to all the more broader information that Kat has given. So thank you so much, Kat. So on the Central Coast, we have had 118 cases so far to date, and our first case was notified on the 11th of March. So that's in a 5-week period. And of those 118, so far we've had 100 who have recovered and 18 still being monitored. Of our 118 cases, 89 of those, so approximately 75%, were overseas acquired. And of those, a significant majority were people returning from cruises, not just the Ruby Princess, but a number of others as well. So we really did have a big hit from the cruise ships, as did Hunter, New England, and that's probably representative of both of our populations and how they like to travel. Of our other cases, we've had 24 cases locally acquired from a known case or in a cluster. So we've had two clusters on the Central Coast, one associated with Gosford Hospital and another one among loosely collected friends and family. And then we've had a number of other cases who have been part of clusters in other areas. So people who attended weddings that were known clusters, a few who had visited Sydney and been a part of clusters there. Of our other cases, we've had 4 where the source was not identified, so despite quite extensive investigation of where they might have contracted their COVID, we haven't been able to identify a link to other cases. And we've had one case recently identified over the weekend that's still being investigated. So next slide, please. Thank you. So this is just an epi curve showing the distribution of our cases on the Central Coast. It looks very similar to Hunter, New England's cases. So we had a really sharp peak about 3 weeks ago associated with mainly returned overseas travellers rushing to get home and also off the cruise ships. We had actually been going really it had all gone very quiet. We hadn't had any cases for over a week until we got one notified over the weekend. That one's still being investigated as to the source of their infection. So we're not 100% clear yet as to whether or not they're linked to a known case or not, but certainly investigating that one quite thoroughly. But it had been, in terms of cases on the Central Coast, we had been tracking really well, which is encouraging. Next slide, please. Thank you. So in terms of distribution of our cases in demographics, I'm sorry that the font is so small on this graph, but this shows the breakdown of cases by age group in 5-year intervals. So as you can see, we've got 2 peaks, which really do represent the overseas travellers. We've got a peak among our young adults who had returned from particularly the US and the UK, and then a second peak among our older groups, and they were returned travellers from mainly cruise ships. We've, as similarly to the Hunter, had very few cases in the under 10s. So we've only had 3 cases of our 118 cases, so less than 3%, which again reflects the international evidence that children really do appear not to be affected by this significantly. Next slide, please. Thanks. So in terms of how we're managing our patients on the Central Coast, our processes are a little bit different to what's being done in the Hunter. But overall, very few of our patients have needed hospital admission, which is reassuring, particularly given we did have quite a few in that older demographic that appears to be particularly at risk. Those that have needed clinical review, for the most part, have been managed by their GPs. So at the public health unit, we follow cases up every day to check they're still in isolation and just check how they're going. And for those who reported deterioration or their symptoms, we've been encouraging them to contact their GPs by telephone, and their GPs have, for the most part, been able to assess them over the phone, and if needed, obtain further support from the Gosford Hospital Infectious Diseases team. And we are currently working on health pathways. So we're working using the Hunter New England health pathways as a template to update that to make a Central Coast specific health pathways to further support GPs locally in managing patients. In terms of release from isolation, this is essentially just similarly to as Kat said. The current recommendation for release is based on clinical progress. So that's 10 days post-symptom onset and at least 3 days without symptoms. And for those that are pretty straightforward, you know, they've clearly recovered, there's no difficulties with ascertaining whether or not they're symptom free. The public health unit has been releasing those cases from isolation and providing them with documentation to that effect. We've had a few where they perhaps have been a bit more complicated. They've had a history of cough prior to their illness and they're still coughing, as an example. And for those, we've sought some input from the GP to help us assess the patient and as to whether this is a new or an old symptom. And those ones we've been released in partnership with the GPs. And as Kat said, at the moment, swabs are only required for healthcare workers or those who are working in high-risk settings for clearance. So most of our patients have not been healthcare workers and so have been able to be cleared on the resolution of their clinical symptoms alone. Some people have had symptoms persisting for a number of weeks, which does also seem to be characteristic of COVID, but for the most part, the illness has been about 14 days. So that's the end of my slides for now, but I'll be available for questions relating to anything to do with the Central Coast after the other speakers. Thank you.
Hi everyone, John Bailey from the Primary Health Network here. I just wanted to provide you a brief update on a couple of issues related to the respiratory clinics, masks and a couple of other items. So in terms of masks, we are providing masks to the community respiratory clinics, Aboriginal medical services and to general practices. We've increased the allocation of those over the last couple of weeks, and we continue to be able to access those from the national stockpile. In terms of community respiratory clinics, we have a clinic up and running at Raymond Terrace, has been for a couple of weeks. We hope to have this week a clinic in Erina, and we were hoping to have one in Tamworth. There may be a short delay in that with some building works not yet complete. We're also looking at clinics for Taree and another clinic for Armidale. And we're aware that the Commonwealth Department of Health are working with an Aboriginal community controlled organisation to set up a clinic in Moree as well. And finally, we are endeavouring to source a mobile van to be able to conduct testing in the smaller and more remote communities where access to services otherwise might be problematic. Just finally wanted to let you know that we've been doing some work with the aged care facilities in our region, and particularly those related to the capacity tracker and ensuring that the staff and residents of those facilities have had access to their seasonal influenza vaccine before the 1st of May cutoff. And we're really heartened and delighted to know that by far the majority of facilities have been able to provide those seasonal influenza vaccines to both their staff and residents. Where they've not been able to do that, we're doing some work to ensure that that supply is available. I'll hand back to Tony.
Hello everyone. We're actually now going to get into the Aboriginal health component. Dr. Joel Wenatong unfortunately has called in and won't be able to make it. But standing in for him, I've managed to hook in Dr. Kelvin Kong, who's going to do a presentation. At this stage also, we're going to do a bit of a Q&A after his presentation. So for everyone that's hooked into Slido, please send your questions through so Kelvin can answer anything that you guys want to know.
Wonderful. Thank you very much for the invitation to come here, and it's always nice to be second to Joel. I firstly want to acknowledge the Wobble Country and also my Warramai mob. It's very important for me to obviously acknowledge, but also the contribution they made, the involuntary sacrifices they made for us to be here in these testing times is quite important to acknowledge. I don't have a great deal to say in terms of the presentation, but I thought I'd just convey some of my thoughts in what we're seeing in this kind of pandemic, and it's been quite an interesting perspective, both as a Warramai man, but also as a surgeon working in this local health district. It's been quite good. Our results have been far better than what anyone would anticipate, which is really good news. And I think looking at some of the slides that have been presented both from our local health district and Central Coast is a real testament to the public health units around, which have been doing some incredible work, a lot of investigative work to make sure that we're actually doing well. All that being said, you can see from some of the Singapore data that it can't be everything that we've done, and because we've flattened the curve, it doesn't mean this is going away. I think it's really important for us, particularly our vulnerable communities, to be extremely wary of that, because within a second we could actually go back to being quite disastrous again. And so it's important that we've made these amazing inroads into combating this, but we also need to make sure that we keep this going forward to ensure that we don't get any further outbreaks or clusters. That being said, of course, I'm boring you by saying that hand washing, social isolation and face masks are really important. Interesting, I thought I'd digress just for a second and just talk about masks, because masks are probably the biggest thing that I've been asked, both socially amongst my family, but also amongst the hospital. And obviously the use of PPE amongst healthcare workers and our community is quite important. There are different type of masks that are available, and I think some of the ones that have been coming on the market now, some of the cloth ones that some of the community are making are quite nice and fashionable. But it's important to note and not to get into this false sense of security that if you wear a mask, that it doesn't mean you're not going to be able to get this, and it doesn't mean you're not going to get the airborne viruses that are there, particularly for COVID. And it's important to state that because I think they're quite good, they look great and they're quite deadly, but in actual fact, you can actually feel like you're not doing all that well. Some of the cities where it's working well, such as New York, Israel, and some of the other countries, Japan, Taiwan, they work well because there's big cluster groups there, and where you actually get value of those is actually protecting people around you. So if you've got a cough or a sniffle, whether it's a cold or a flu, not necessarily COVID, then it's important to protect everyone else that you're going around to make sure you're protected. So from that point of view, it's quite good. From the surgical mask point of view, there's no point getting a surgical mask because most of them are similar to the cloth masks that you're using, and we have a depletion of stocks of those, so we want to make sure the healthcare workers can use them. But as a healthcare worker, and particularly when you're in contact with our patients, I certainly would encourage you, if your AMS has them or the public health unit have them available, to use one when you're contacting vulnerable patients. I don't think that's actually a bad idea for healthcare workers particularly, but not necessarily for community. And then we go up to our surgical masks, which we don't really want to go into here, but obviously those N95 or the purifiers or respirators are quite advanced and don't really need to. It doesn't really provide any influence for us at the community level in what we're doing in helping, and certainly just makes it harder for us to do our job when we're actually at the cold face of intervening with patients with COVID. That being said, the biggest thing I'm finding also quite hard to manage is the isolation mob are experiencing, and it's really, really tough. And I think the reality of all this that we're talking about is that people are actually stuck in these kind of environments and not being able to work very well in just engaging with other people. And it's quite endearing to hear phone calls come to my phone talking about different ways in which people are engaging. And I was only saying earlier that I arranged a Zoom meeting for my family on Easter, because we normally get together on Good Friday. And we had, I think it was over 50 blackfellas on the Zoom meeting, all trying to talk over top of one another. And I recorded it, and I'm going to use that, so I apologise to my family in advance. But it was one of the funniest sessions I've had, and it really brought us all back together, because obviously it's a very challenging time, but it was really important to somehow engage and connect again. And I think some of those things, and maybe it's a challenge out there for our health workers to see what kind of ways we can engage community without obviously affecting our social isolation, and spreading some of those fun ways in which we can do things. Moving on then in some of the thoughts around this, I think one of the interesting things for me on a more serious note is how well this public health campaign has come together, and how strong Australia has come together in doing this. One of the good things about that is it shows us that when there is a public health crisis such as this, we can actually work really well together. And the challenge is for us as healthcare professionals now is how we can actually translate that into our Aboriginal health. Aboriginal health hasn't been in a crisis for 200 years, 250 years, and yet we keep pandering around some of the issues in which we can actually deal with these. And so when we talk about social isolation and we suddenly create these hotels for people staying when mob don't have communities and houses are staying, then it's actually a slap in the face when communities don't have a place to stay and we're talking about social isolation. So it's important for us as professionals to advocate strongly for those who don't have the kind of things that we can endure, but also translating what it means for social isolation in a family where there's overcrowding. What social isolation means when there's no income coming into the family to get the food. What that means when you go into the supermarket or you go into the places you're seeing and you're copping the racism that you occur all the time because of this, and extrapolated and made worse by these kind of events. And they're questions that I think our society need to look at ourselves at and really think about what we're doing. The punitive measures around social isolation often impair our community as well. So that if you're going for a walk because you've had an argument at home or it's been a bit crowded at home and you get picked up and you get fined $1,000, then there needs to be some kind of adjustment in that and how we can actually change those punitive measures to make sure we support those who don't necessarily have the avenues of people who are stuck in the eastern suburbs with nice big houses to go to a different room and isolate. And I think they're important things we need to think about and try and challenge ourselves on what we're thinking about in those measures. Finally, because we're doing so well, I think some of the de-escalation methods that we're now starting to talk about are really exciting. And I think they're quite exciting for me because it means we get back to some kind of normality. But more importantly, the challenge is for us is when we do these de-escalation measures, how do we put our mob on the first priority of the de-escalation? So if we've got big backlogs of waiting lists for surgery, if we've got big backlogs on patients that need to be seen in outpatients, if we've got big backlogs on chronic disease that needs to be dealt with, surely when we're coming back to de-escalation, that our mob should be the first in line to get these services needed. Because one of the biggest things that's happening at the moment is because we're not seeing our doctors for the general care they're looking after, that these chronic diseases are building up and getting worse. And it means that we're going to have to repair all this when it unwinds. I might leave it at that for the moment. Questions?
Yes, there is a couple that you could answer. One is, and we were just talking about this before, Kelvin, but what is the situation for remote communities Australia-wide?
We're quite good. I don't have the numbers obviously at hand, but there hasn't been a big increase in numbers, certainly in remote communities at this stage. And I think one of the wonderful things, I still think to this date, there's no deaths in the Northern Territory, which is wonderful. But obviously keeping that on top of that is quite important because it's very hard, particularly the more remote we get, the more we're seeing higher density, the more we're seeing overcrowding, and particularly some of the frightening things that when the big urban centres are actually getting closed down, that a lot of people are moving from main towns back to community, and that actually adds more stress but also adds more to the household, and that's quite important to be wary of.
And just another one, what are communities doing around social gathering for our mob? We find it really hard for our mob to keep away from each other. Do you have any suggestions around that?
I think that's really hard, and there's been some sorry business which is very challenging to try and work around. I really think that we need to come up with novel ways, and one of the beautiful things about our community is that the way in which we think and the way in which we can actually do things differently is something that is a positive, not a negative. And I think we need to challenge each other on ways to do things that make us laugh. And again, I come back to that Zoom meeting I made with my family, and I still think it's one of the funniest things. When I've had a really stressful day, I come back and I replay that, and it makes me laugh every time. But yeah, conversations, making sure you reach out, so getting on the phone people, and sometimes you need to call someone that, you know, may not necessarily be a great conversation, but at least just making that link and making sure they're okay. Text if you don't want to talk to them. But also, you know, sending a video of the kids or someone doing something funny and just text it to other people makes everyone laugh, which I think is really nice.
And just one from me, I'm sitting here thinking as you're talking, how important is it to continue to access your GP if you have any health concerns, and how would you do that via telehealth? So can you talk a little bit about telehealth and what that actually means for the mob?
Yeah, sure. I think one of the wonderful things coming out of this, I think, is the ways in which we've been able to think about delivery of healthcare. And delivery of healthcare in the traditional format is obviously going to your doctor and having an appointment. And I think for us, it's been a long time in the process of looking at ways in which we deliver better healthcare. So AMSs, ARCHOs, and obviously Centres of Excellence around Aboriginal care makes it a lot more inviting for patients to come to. But on top of that, then we've now been given the green light to look at other ways in which we can make contact with patients. So whether that's by telephone, whether that's by your phone through an app such as FaceTime or Zoom or one of these other factors, or there's a whole lot of other different avenues which we're actually exploring at the moment. There's a few that we've found have been fantastic. One of the beautiful things about this is that you can have a live appointment with a doctor, see their face, see their reactions, and actually have a consultation to work out what needs to be done without actually leaving your home. And I think that's really exciting. Most people have got a phone, so all you need is a phone, but if not, you can use a computer, and if you don't, you can just use a telephone. And it's really nice because now the government's finally seeing the benefit of having these links with communities and with people and our population, particularly the more vulnerable and the harder access, so that you don't have to get in a car, travel 5 hours, or even get in the car and try and get a park at the hospital, which is a nightmare, and have these interactions. It means then that your chronic illnesses can be measured at a real-time basis and more frequently as well. And so these kind of new avenues, I think, will be explored much further when we get out at the other end of the de-escalation plan, but also be able to, I guess, ramp them up and use them in other places, which can actually help us all.
Thanks, Kelvin. Next is going to be Christy Crooks and Kylie Taylor from the Public Health to give you some information.
Hi everyone. I'm not on the agenda, but I wanted to hijack Kylie's presentation, so I thought I would tackle on and start it. So before I start, I'd like to acknowledge that we are meeting on a Wobble Country and pay my respects to elders past, present and emerging. I'm Christy Crooks, Aboriginal Program Manager and PhD candidate with the Public Health Unit based in Newcastle. I'm originally from Dubbo and I've got spiritual ties to the Lightning Ridge area, but I've been living on Wobble Country most of my life.
And my name's Kylie Taylor. I'm a Gomeroi woman from originally from Walhollow in northwest New South Wales. Been living in Tamworth for the last 22 years. I'm an Aboriginal health worker working for the Public Health Unit based in Tamworth. And yeah, also like to pay my respects and thank the elders of the Wobble Country for letting us present here tonight.
So before we start, I'm just going to provide some background and context to our presentation. So back in 2007, our Aboriginal communities were concerned about some control strategies that were in place to prevent an outbreak of pandemic influenza. So communities had asked us to develop better ways and strategies to make sense for communities and families. So they reached out to the Public Health Unit and we led a project to develop some strategies around pandemic influenza for our Aboriginal communities. So the work started locally in Tamworth and Inverell, and then it expanded to include communities across Australia around far north Queensland, Cairns, Townsville, Western Australia, Palm Island and the Torres Strait. As you know, your location doesn't necessarily mean less risk, but further from the cities and towns you live, it usually does mean less access to health infrastructure, less access to healthcare, timely testing and results, and disease burden and worse outcomes. In 2009, the first person to pass away from swine flu was an Aboriginal person living in a remote desert community. And just like we're seeing now, it's the fly-in, fly-out health workers who are meant to be looking after us that are putting our communities most at risk. Even though in larger cities there are more people, it's more densely populated, there are more large shopping centres, more public transport and larger workplaces. People spend less time meaningfully interacting with each other. In country and rural areas, there's less people, less public transport, less big shopping centres, but more people are spending more time together. So there are meaningful and longer interactions and spent closer together. Therefore, this can create more risk, especially for our mob. Our mob are more transient and we travel a lot as well. And we spend long hours in cars together and often come together from everywhere for sorry business and other important family gatherings. So there's ongoing systemic problems for many years of government failure to adequately address poor housing, health hardware, food security, water and sewage. So now we're seeing reduced access to food, medicines and other essentials that are impacting on our families and our communities. We need a policy and response that prioritise our communities and our families, and the allocation of funding is inadequate and the shortfall will add extra burden to our AMSs. So what we learnt from our 2009 pandemic influenza research was that Public Health Unit is currently highlight the consistent messages that can be localised and understood. So what we found is that one-size-fits-all approaches to pandemic control policy is unlikely to work. We need family-centred approaches, so social distancing won't work as well for our communities and it goes against our ways of living and interacting with each other. Communication strategies need to be culturally appropriate and should be localised, personalised and humorised. We need to address Aboriginal health needs that considers the social connectedness. We need to place and value our culture and strengthen and value that. We need to have respectful engagement to develop appropriate policy. We need Aboriginal people leading and establishing culturally appropriate governance models. And we also need our local community leaders, champions and organisations, as well as other representatives. Now I like to show this picture because it shows a photo that was taken from the New South Wales Ministry of Health in Sydney. So looking at this, you can see we can't really see any of the roads or the buildings or the people or the cars driving it. To us, this represents that health decisions are made by the government that usually are for us and not with us. The public is told and not asked. We are directed without being included to freely think and come up with solutions for ourselves, our families and our communities. Plans are usually made for everyone else and we are tacked on at the end, often an afterthought and added in the appendix. They usually put an Aboriginal or Torres Strait Islanders flag or some nice artwork and change family to mob, throw in a deadly or two and think that their strategies and fact sheets are now culturally appropriate and make sense. There are not many Aboriginal voices sitting at the table making these decisions in politics or in senior leadership positions or planning or designing and policy. There are very few voices informing all of this for our people. We like to work from the ground up. So previous work that we've done, communities have told us that we need to work in collaboration, and if we work in collaboration together, people are more likely to take notice. That's where we fell down. We should have come together in the first place instead of the last minute. When you put things in place, the process will follow. We're also told that there was a lot of distrust and scepticism about the current Australian policies on containment around pandemics. Community has seen how the government can easily change the laws to suit them and the suspicion of the anti-discrimination legislation, so this could happen. A lot of work was done back then and has informed the work that we are doing now around COVID. Often research is done on us, not with us. So we had to be careful because Aboriginal told us that research now with pens and paper and not scalpels. We had to honour their feedback, their time, their input and their solutions to the issues. The language used for these type of responses and public health actions all brings back the memories of colonisation, assimilation and segregation. Being controlled, monitored, under surveillance, all these things are very raw for our mobs and families.
Thanks, Christy. I think you did a great job hijacking the presentation so far. I think we hijacked it in general. You came here, I think, listening and wanting information on how you can best communicate to Aboriginal families and clients. But while we have a captive audience of GPs and other health providers, we thought we might share some lessons on how communication's two-way. And a lot of this stuff we've been saying for a lot of years, and we could pull this presentation together in about 15 minutes because it's nothing that no Aboriginal person's not shared in the past. It's in every report that you'll find. It's in every feedback document. It's in, speaking of feedback, it's in it's in every policy almost ever written. So thanks for all those people who've contributed to that space in the past, and we're here to continue that work. So the Public Health Action Plan so far, as Dr. Kat has already explained, whenever we see COVID, we want to identify the cases early. We want to isolate the case, so take them out of the community and keep them at home to help stop transmission. We want to trace contacts, so that's all the people who've been around them. We want to repeat that over and over, and then the government's put in some measures around social distancing and preventative public health measures. That all sounds pretty simple and pretty normal, but how do you communicate that to our families? Like, how do you make all these things make sense to our mobs? You've already heard from Kelvin and others and Christy about the community being unsure how we take this on. You know, there's the houses are designed inadequately, there's not enough houses, there's some crowding, but there's lots of challenges. So how do we make all of this work make sense? So we usually throw together a few fact sheets. The ministry comes up with some, Department of Health come up with some, and they all look pretty standard. They try and address all the key messages for community and how we might go about getting that message out to Aboriginal communities. And as we said, the old approach is usually just whacking a flag on it, and as Christy has already said. But that doesn't actually make much sense to our mobs. So we like to communicate in a way that makes sense. We use metaphors, we use pictures, we use videos. There's all sorts of different ways that we can connect with our families that actually make sense to them. So we've got a case of COVID. Who's got it? So this is the way we explain all of that language that Kat's used earlier, that Dr. Kathryn Todd's used earlier, that you'll hear on the radio and on the TV and every time you watch the news about, finding cases, quarantining contacts, and the public health unit will talk to them over the next 14 days and keep an eye on them. This is how we make it make sense to our mobs. So who's the case? Who's the unlucky person who's got COVID? That's me. So I've got it. So what we want to know is how I got it and where I got it first. So that's my exposure. I'm sorry to all the GPs out there in GP land. You guys are probably well aware of this. But tonight was really informing a lot of the AMSs and the Aboriginal services about what's going to happen when we start seeing cases in Aboriginal communities. They really needed to connect to this information and for what it means for our community so they can better plan and prepare and coordinate their services for the best outcomes for our mobs. So I've been diagnosed. The first thing Public Health Unit want to know is, where and how I got it. So the source of my infection or where I contracted it. You'll hear those words thrown around a lot. So they want to know where I've been in the 14 days before I got symptoms. At the moment, most people in HNE, as we said, have either returned from overseas by boat and cruises. I'm sure you've heard of some famous ones now. Or I've returned on a plane from holidays. Or there's some hotspots, as Dr. Kat mentioned, Lake Macquarie, Manning, a few other places of interest around Newcastle. You know, I may have been visiting those places and then got sick, or I've been in contact with a definite confirmed case. The contact is usually very close contact. As Dr. Kat said, you know, we're sitting close together for more than 15 minutes, being intimate, or, you know, we're being in the same place or room for a lengthy period of time, you know, up to about 2 hours. So if we're not close to close, it's that lengthy time we're spending together. It's not usually passing somebody in the street, or it's not usually, you know, being out in the parks with people. It's usually that close, prolonged contact that you'll see. You'll see in the media at the moment that, you know, a lot of the previous cases have been from mass gatherings, such as weddings, funerals, and also dinner parties, where lots of people come together from all over the place. So I've got it. We've worked out where I've got it from. I'm not sure where I got it from because I haven't travelled. And then once we know that, we want to move forward. We want to look at the people or my contacts who I've been around and who I could now give it to. So all of those people near and dear to me, and some of those people just near to me. So who are they? So that's my family there, back home. I think they're even listening in. Hi guys. And because they've been around me, we all live together at home, so I've got that definite household contact you might hear. And then there's also some unfortunate workmates as well, who are near and dear to me as well, I might add. So it's the people who I've shared space with closely, or I'm working in the same office with. You know, there's some other people who would be considered my close contacts. And what we want to find out about them is, determine how long they've spent with me. Some people, there'd be some other workmates who would be my casual contacts, who I might have just made a cuppa with in the kitchen, or, you know, spent a couple of minutes with at the photocopier, but we're not that worried about them. They'll just be my casual contacts. So, as for my close contacts, those poor guys now have to go into quarantine for 14 days minimum. So I'm sick and I'm at home. If my family chooses to stay with me at home, or if we choose not to separate, my family, as Dr. Kat said, will need to be around me for another 14 days after I'm cleared and after I have symptoms. So really, for families and mobs who stay together, that could be a minimum 28 days. So we really want to try and, you know, see if families can find a house separately. I might go and, you know, stay with somebody who's got a vacant house or a spare room in a bigger house, because there's, you know, 6 of us in our family. And that's the work that Christy and myself and the Aboriginal Health Unit, and that's a lot of work that we're doing behind the scenes to really work with families when we have identified people who identify as Aboriginal or Torres Strait Islander. We really want to help them sort out what's going to work best for them and their family. It's not a directive approach. It's not being told what to do and how to do it. It's a support system. It's to support that family, it's to support that sick person, and to support their family members for a good outcome. We want to try and reduce household spread, so we want to try and stop me from giving it to my family. And the best way we can do that, if I've got, you know, symptoms and I can't isolate myself at home, I can't use my own bathroom, I can't stick to myself in my bedroom, my house is crowded, or, you know, I just don't have the ability to do that. And the Public Health Unit will actually work with any cases or high-risk contacts, and we will help find accommodation for you, and you'll be put up in a motel, and that will all be funded by the ministry, and meals are provided for that person, but it has to suit that family. It has to suit the person who's sick. If you choose to stay in your community, then we'll work with you to help that happen as well. But it becomes your choice, not the health services choice, and it's made in collaboration with you and your family. So we've got my contacts. They have to stay home, and we want to monitor them for 14 days. So we'll call or text them however they've decided they want to be contacted, and we'll make sure that they don't develop symptoms in those next 14 days. They're likely, some are likely to go on to develop the illness. If they do start to get sick, then what we do is we have a plan in place that we've developed with the family again, They'll use their normal medical pathways or their normal GP. We would have spoken to the person at the very start to identify if they're connected to an AMS or if they have a private GP, and we'll work with that family to ensure that the minute anybody else in the family starts to feel sick, or even myself as the case starts to get sicker, that we have a plan in place on what that family needs to do straight away. We don't want people staying home if they're unwell. We want people getting straight to the GP. For myself, I'm sick, remember, that my symptoms really start to get bad from about anywhere from day 5 to 7 is when we're seeing people really crash with this. So, we'll plan all that with the family, and we'll talk with AMSs if that's the normal care provider, or we'll talk with private GPs about how we can make things work for your family. We've sent you to the ED, or hopefully PHN's got that mobile testing van somewhere by then, or hopefully some of the bigger places like Tamworth have some better testing in place. And then once we have that, you go and have your tests, and hopefully you're getting it back very timely. And if you test negative, then you still stay a contact because you're still around me for my family. So they're not in the clear, because if you get sick on day 2 and get tested on day 2, that doesn't necessarily mean that you're still not incubating COVID. It still doesn't mean that you might not go on to develop COVID day 13 or day 14. And even if you don't develop COVID and you develop some other flu-like illness or respiratory illness, that's still pretty bad for your family. So you still should self-isolate if you're sick. So if it's one of my kids, I'd still want to be trying to keep them separate, because while our chances of getting COVID are still fairly low, and we know it's mainly affecting older people or people with underlying medical conditions, the flu every year actually takes out a lot of our elders, and it really knocks around our young kids, so our little ones under 5 and our young people. So so we don't want them getting flu either. So the social distancing has really been helping with that. And as I said, just because it's not COVID, you still should be self-isolating at home and trying to really keep your distance if you're unwell from everybody in your family. I'm the one in my family who's unwell, so I should be wearing a mask. I should be cleaning up the areas that I have to share with my family if I choose to stay there. Should be doing extra cleaning, using hot soapy water on any surfaces, and lots of hand washing. We can't stress that enough. It doesn't matter about the products you use. They don't need to be fancy or antibacterial for home use. It's how often you're using it. It's breaking those daily habits. We'd much prefer you to be able to clean, 5 to 10 times a day using warm soapy water for hand washing and hot soapy water for cleaning your common surfaces, rather than cleaning once a day with bleach or once a day with your Domestos and those products. So really, and any of those soapy products work. It doesn't matter. It can be dishwashing liquid if you can't buy the pump soaps, or it can be shampoo. Anything that soaps up is really, good at breaking up this virus. Okay, so we've worked out if they actually don't have any symptoms after that nominated time, then they're free to go back to normal and start to be able to go for a walk again, say, because we still want people to socially distance, of course. But if they do actually test positive, that contact now actually becomes a case as well, and everything for my close contact is actually repeated. And so if it was my hubby Jeff, everybody who he was around in the weeks prior, they become close contacts. If it was Christy, then she becomes her husband and her daughter and other people she's been around, they become. So this whole process of repeating it over and over, this is what we meant by that. So we know this is going to be extremely hard for our mobs because we live in small houses and we have really big families. We don't usually have separate rooms or 2 bathrooms. As Kelvin said, there's a lot of really inadequate and poorly designed houses, and poor distribution of houses for our mobs. The crowding is there because there's not adequate houses, or it's been 3-bedroom houses built for a family of 10. Even for my family, we've got a 4-bedroom house, but my 6-year-old sleeps right beside us because she doesn't have a bedroom of her own. So you need to have a think about how this might impact on your family, some of the decisions you might need to help your clients make to have them safely self-isolate at home, or, you know, really thinking early about some of your clients who will find this challenging, and how, you know, you can have a chat to Christy and myself and how we might be able to help you work with the other key support agencies to help this happen. You know, lots of our kids co-sleep as well. They like to jump in bed with us. This could be a chance to kick those kids out finally. You know, you have to really think about, you know, like I said, changing some of those practices now, and, you know, because these things will help down the track. You know, you might think it doesn't apply to us now because it's not badly, you know, infecting our communities. But as I said, these are the little daily habits we can start to practice, and it only has to be, you know, for a couple of months. This is not lifelong, this is not life-changing, you know, but these are the extra things we can do now. The government's done sort of everything they can, you know, restricting the mass gatherings, restricting our movements in public. A lot of the stuff now is actually up to us, but we need the health hardware at home to be able to do that. We need the space at home to be able to safely socially distance. We actually need those enablers within our house to be able to take on these punitive public health measures and other health measures, you know, that have been asked of us. And that's where, you know, our AMSs and, you know, our local support agencies know our mobs the best, and, you know, and they know each and every family, just about all of our communities. And, you know, if we haven't engaged those guys just yet, then really that's my advice. If you don't know enough about the local Aboriginal people in your communities, then really connect with AMSs now, and try and connect with, if you don't have an AMS, try and connect with the Land Council or other Aboriginal community controlled organisations, because it's going to be too late if you leave it too long. So once that's happened, then we've looked at the people who I've actually been around. Had this been 4 weeks ago now, sorry, when I did this presentation it was actually 3 weeks, but from the middle of March I think was when all the new things came in place, all the new laws came in place, and so contact tracing now for me would only be 9 people, so that's fairly manageable for the public health unit, especially for an Aboriginal family. It would be just my family, and it would be my workmates. Whereas if that was a month ago, I actually went to a 50th birthday party that weekend. So it would have been approximately 60 extra people, because of course when you catch up with all the mob and you're spending 5 or 6 hours together, there's lots of cuddling and kissing and hugging and sharing food and sharing drinks and sharing microphones, fighting for karaoke and doing all that stuff. So, you know, we do, as Christy said, it's that close, intimate time we spend together that really puts us, you know, more at risk once this hits our communities. We're not at greater risk at the start, but once it hits us, we're at greater risk of more serious health problems, more deaths, more morbidity. So that's why we really have to try our hardest to keep this out of our communities. So you can see, the less people you have around you at the moment, the better. The less chance you're exposed and the less chance you catch it. And if you do, there's less people who you actually pass it on to. Plus there was others not even in that picture. I actually play OzTag a couple of nights a week, and I train for 3 hours on a weekend. And then there was also possibly some other people at work if it was the month before, because our workplaces have been implementing social distancing over the last sort of 10 weeks. So we've really, you know, tried to change our workplaces a bit. So if one person in our family actually gets COVID, it's our responsibility collectively, you know, to stop everyone else getting it. If we can stop household spread within each of our houses, we can help stop community transmission. It's our job to protect our mob. So we've talked to community now about all of these new words. We've told them, you know, we've used all this foreign language to them, and these are some of the excellent resources that have been developed by some of the ARTRALgia services, by some of the local AMSs, by other government departments. Each state and territory have developed their own resources. I really, encourage you to jump on and have a look. Queensland always sort of do the best stuff, and they do it very early. You know, they're able to design and disseminate their stuff very quickly. It seems like they have a really good process already in place for this stuff to happen rather than having to wait to jump through all the hoops like some other states. So yeah, that's a key learning we can all take on board. And there's some that been developed by the Aboriginal Health and Medical Research Council, but also the local AMSs have also been really proactive, and you know, instead of waiting around for a lot of this stuff to come through, they've actually developed and designed their own resources and disseminated them through their networks. And so I really encourage you to check out their Facebook pages and to find out, you know, some of the, you know, the awesome work that they've done, you know. And it's not just resources for, you know, for posters and pamphlets. What people really want to know is, you know, what is COVID? How do I prevent it? How do I catch it? How do I spread it? What are the symptoms and what do I need to do if I get sick? If you check out the New South Wales Health website, they've got lots of fantastic resources. But as you know, it changes all the time. It's changed over and over. Our public health physicians and nurses struggle with it each day. So how do we expect community to understand it, you know? People need to get messages in their local languages in ways that connect with them and make sense with them. Simple, clear messages, not too wordy or not too much medical terminology. We need to use metaphors and pictures for people with lower literacy levels. Tell a story that makes sense to them, you know, and try and make it relatable. Check for understanding and how it relates to them and their family. A lot of the stuff that's developed from the ministry and from the Department of Health it's not really aimed at our mob, because if it was, you know, they would understand how hard it is to socially distance. They would already understand the challenges that exist in our communities. Have a suite of readily available resources with consistent key messages that can be localised to each community, using local colours, artworks, local legends. Somebody who they know or somebody who everyone knows. Using different mediums, short videos and animations, not just printed resources. Using social media, so using the different platforms and channels to target the different age groups and users. You know, the oldies don't like the hip hop videos, but the young people do. You know, they're all into TikTok and Snapchat. You know, and it's that middle age group from the sort of teenagers up to the early 20s who are really not getting those messages about staying home. So, you know, how do we get that social distancing out to those little social butterflies? You know, most of our mob are on Facebook or Instagram as well. And then there's Twitter, where there's, you know, far more advocacy, you know, for trying to break down and trying to input the government policies. And all of these definitely have a place. There are plenty of resources out there, there always are. And if you don't know where to find them, you're not looking hard enough, or you're not connected to the right people. Another key message there. So, you know, if you don't know where they are, try and find out where that is, because they're not that hard to find. So where do you normally get all of your information, and why are Aboriginal people not usually represented in the information you're usually finding? And why do we feel like those messages don't make sense to our families and communities? So yeah, if all the information and resources that you're sharing don't represent Aboriginal people, there's not an Aboriginal person on a poster, it's not usually using culturally appropriate terminology, you're looking in the wrong place. So back to Christy's, you know, ground up approach. This is what we like. I'm sure a lot of people have actually seen this slide. It does the rounds on Facebook. It does it everywhere, and everybody shares it. Oh, I love this slide. I treat everybody equally. Well, we know you don't, because we don't treat people in a wheelchair the same as we treat people who can walk. We don't treat seeing people the way we see people, the way we treat people who can't see. So we don't treat everybody equally. We need to treat people the way they would like to be treated. We need to ask them how they would like to be treated. And we can't assume by giving the small child a couple of extra boxes that that's going to work either, because guess what? We all could be born equal, but we're not born with equal opportunity. People actually start off less equitable than others. We're all starting on different platforms. We're all starting at a different starting point. So this is where we really need to think about our health service delivery and design. So the main messages from government don't actually fit with our ways of knowing, being and doing. Our cultural connectedness is our cultural strength. Now all the key messages are to physically distance, stay apart, stay away, don't touch, don't hug. You can't come and give cultural support to any family going to appointments and in hospital, even though that cultural support is usually there. We turn up in big mobs because that's our cultural safety. You can guarantee there's been a bad experience in the past, and the family come together because they've thought out the visit very well before they turn up. There's been that bad experience and they want that extra support around. You need to be able to break up if somebody's got to stay in or stay for longer. So yeah, people like the health services really need to see those extra numbers in ED, those extra numbers in ICU outside of COVID as a cultural strength. They need to really think, oh wow, how awesome, this Aboriginal family. It has lots of people here who love them and support them and who've come to help them while they're sick. Gee, I wish my family was like that, rather than seeing it as a barrier. And as Christy said, it can't be a quick fact sheet fix like it has been in the past. It can't be that. We just don't want that. It has to be more. It can't be the fact sheet. You can see in the second picture there where it says equality, the fellow in yellow, there's a hole in the fence. He's peeping through. So this is what our mobs do. We had a meeting last week. So we look at creative ways we can get around that fence and through that fence. We don't usually fix the system. We help each other out. That's our way. We support each other. Last week we had a meeting. One of the AMSs didn't have enough vaccine. One of the other services said, oh, you can have some of ours. We've got too many. That doesn't fix the system. That doesn't fix it from the ministry. It doesn't actually allocate the resources according to risk. So we need to really fix that system. By treating everybody equally, we give everyone the same chance, the same opportunity. We don't actually make any difference at all. We think about everyone in our communities as Aboriginal people, not just those living in them, but those who have been removed or displaced from their country or homelands, those who have been forced back into towns or forced out of towns, those children that continue to be taken as well, those who couch surf or are homeless, and especially those who are disproportionately incarcerated and who will eventually end up back in our communities. We need that equity approach for everybody, not just those of us who can actually access healthcare at the moment. If we build a system for those who aren't turning up to it and who find it hard to navigate, then the rest of us thrive. Those of us who are healthy continue to get healthier. Nobody loses out. So this is what we need. We actually need justice instead. We need everybody to help smash that fence down and get rid of it altogether, because the equity slide in the previous one, it doesn't actually fix the system problems and the systemic racism. So how do we achieve it? And this is the communication I really need everybody to hear. We need to demand space and voices at each and every table where decisions have been made. We need cultural governance. As Christy said, I'll keep reinforcing these messages over and over. We need local leadership to enable communities to have choices, to make decisions that work for them and their families, according to their situation, their services and the supports that they actually have. They are the experts here in their communities, not us. And we need the upskilling of Aboriginal health workers and AMSs and Aboriginal community controlled health services to compete on a level playing field. You can't keep doing the same thing and expect different outcomes. We need the same key consistent messages, but understood in a way that makes sense to the families so they can make the choice to keep their family safe. We need to talk through these issues and connect with the families and give them the practical solutions and ideas on how they can take the key messages on board and how it makes sense for them. At Population Health, we've actually implemented a cultural support process. So each time an Aboriginal person identifies, they're followed up by our team. They're offered cultural support, talk through the challenges, as I said earlier. We come up with solutions for the family that make sense for them. They're empowered to make those decisions. They know their family the best, not us. It's knowing the pathways for the family to offer them the support that's needed and empowering them that will come up with a plan to keep themselves safe. Being supported to stay at home and home isolate, or being supported to relocate. We're connecting them to the local Aboriginal health workers if needed. This could be the AMS health worker or the Aboriginal health unit health workers, or it could be public health unit staff. Again, that choice will be theirs. We won't tell them who they have to go to. It will be their decision. We all deserve that choice. But whatever decision we make, we'll ensure it doesn't overburden the AMSs or the ARTCHO sector, who are already providing their regular service to to complex clients with special needs and extra challenges, as well as enhanced COVID-19 response, as well as trying to provide flu clinics and keeping our families safe from all of the other things that they do. We've engaged all key stakeholders to work together for a coordinated response to ensure community has the best chance of keeping this out of our communities for as long as possible, and to prepare and respond appropriately when necessary. We've established the governance group that will action and address system problems, just like in this picture. We'll fight for system change and improvements. We'll break down that fence if we need to, and so should you. We all have to build towards equity. It takes both people using their privilege and their experience to do this. And if you really want the fact sheet fixed, there's a few there for you you can choose from. And there's some really good ones now for Aboriginal communities specifically. And there's some other information there. If you like that, we can get that out to you. Christy, to bring it home.
Well, how can I follow that anyway? That was so inspiring, Kylie. Look, we just need to change the system. We need to challenge the system. We need to dismantle the system if we're going to see improvements in our health. We as Aboriginal people know the issues that impact on us, and our way of knowing and doing should guide the development of all health policy practice at all times. We need to be empowered, be self-determining, and build the capacity and leadership of our people so that when we have the power over our destiny and of our children in our communities, our children will flourish. They will walk in two worlds and their culture will be gifted to their country. For us to have a voice, this means non-Aboriginal people have to give up some ground, make some space and time so that our values and our ways of seeing the world are honoured and respected. It also means that the Western biomedical approach of addressing health issues and seeing the world from the top down is not the only way of addressing health, but our knowledges and our practices working from the ground up and being informed from the community and seeing health as a holistic approach must be valued. If we continue to work and develop policy and programs that are not led by us, then we are more likely to yield the same health results, perhaps with little to no benefit for our people and our communities. We need to be positioned in the centre, in spaces where there is shared empowerment and power. To ameliorate any of the health and social impacts of colonisation, we need to inform, develop, lead and govern health policy and programs. So just to finish, achieving health equity is challenging, but we have to keep pushing and challenging the dominant voices who make decisions for us. The voices who are making decisions for us, so we can then have an equal and real say in the decisions about us. We've got lots of people and organisations and groups that we would like to thank for helping us with a lot of the work that we've been doing in the background. Our AMSs across the district, our Aboriginal Health unit staff within the Hunter New England, our public health colleagues, all members from our Hunter New England Aboriginal Governance Group on COVID, and all the communities and families that have trusted with us with their stories over the years. So thank you for listening to us tonight. We hope we've inspired you. There is lots of work happening in the background to make sense for our Aboriginal people in addressing COVID. We'll across to Susie Mabry now, the Hunter New England District Coordinator for the Aboriginal Family Wellbeing and Violence Prevention, who are presenting her work from Tamworth.
Thanks, Christy. I'm just going to try and share my presentation with you all. So just bear with me for one moment. I'm not sure if that's coming up right now. No, that doesn't seem to be working, so I might just talk through my presentation. So thank you for having me here with you this evening. I'm I'm really honoured to be part of this webinar. Before I begin, I'd like to acknowledge that I'm on Gomeroi country tonight, and also acknowledge the many First Nations lands gathered by all of those in the meeting. I'd like to acknowledge elders past and present. I'd particularly like to acknowledge my Aboriginal colleagues, Aboriginal families and communities, and the broader services working tirelessly in this pandemic to keep our people well and safe and supported. So firstly, I'm a Gomeroi woman, and my working role is the District Coordinator for Aboriginal Family Wellbeing and Violence Prevention for Hunter New England Local Health District. This work I'm involved in allows me to guide a focus for our services, workers and communities on the strengths and Aboriginal healing frameworks for our people in the face of trauma, both past and present. And yes, COVID-19 potentially presents us with another trauma to overcome and heal from. It is amazing to see that even in the isolating and polarising circumstances, our people are rising with support and connection to each other as we do. And we are focused on our most vulnerable, being our elders and those who are unwell, and caring for each other. So I've been asked to speak tonight to you guys about grief, loss and sorry business. I don't profess to be an expert any more than any other First Nations person who's had more than their fair share of grieving and sorrow. COVID-19 is giving us many new challenges, and especially if we're faced in the midst of it with sorry business, as is the case in many communities. The challenges sit very much with the restrictions placed on gatherings and funerals, for travel, and even for being able to visit and be with families, whether that's in facilities where our people are sick or being cared for, or in the homes of our family and loved ones. For the most part, our communities understand why the restrictions are necessary, but when faced with the loss of a family or community member, these restrictions are very hard for us to manage, given the collective way we respond to loss and grief, which is fundamental to our identity and our culture. To describe what we know sorry business to be in some more detail, sorry business is foundational to our First Nations cultures. Sorry business describes a period of cultural practices and protocols associated with death and dying in particular. This includes conducting ceremonies or funerals for the person that has passed on. Our ceremonies and funerals are often large gatherings of our families and kin from all over the place, requiring travel and reprioritising of our work and our family obligations. Sorry business can also describe a period of mourning and additional responsibility of visiting family and caring for those closely impacted by loss. Sorry business also encompasses our telling of stories and yarning about our loved ones who've passed on, and of sharing meals, of cups of tea, of laughs. That's been talked about a bit tonight. In general, our homes in a communal and collective way. Singing, going bush, being on country, all of this is part of what's necessary when we're going through sorry business, depending on where we're from and what our practices allow to happen. So I guess an Anglo way of determining priority for attending funerals and being involved in grieving is not relative to our kinship and responsibilities and cultural practices during sorry business. Along with the cultural business, sorry business comes with grief and loss, and our practices within sorry business allow grieving and sorrow to be shared and worked through with each other. This in itself brings some healing and comfort as we grieve the loss of our loved ones. Sorry business can be perpetual in our community, and for some who've experienced many tragic losses, the feelings of grief and loss can be overwhelming and triggered by further loss. This, we know, is a great burden in our families and our communities. So the way we need to conduct our sorry business is being impacted significantly at this time. This in itself is a cause of compounding grief for many. The inability to mourn collectively or to be on country and just be a part of what would normally occur is traumatising for many of our people. It also impacts on how we show our final respects to our loved ones in a way that we know should occur as the last thing that we would be able to do for them. Sorry business can also be relevant for a person who's unwell or preparing to pass on, and many will come and pay respects and to show care for the family and close ones. Some will wait close by where this loved one's being cared for, and family will ensure a vigil is maintained around the clock to care for everyone during this time of passing. This practice is also being impacted by COVID-19 restrictions in this time. Given the social distancing measures, again, our inability to travel, our access to be able to be in hospitals and facilities where people are being cared for, or even just to go and visit in our family and people's homes. Sorry business can also be part of grief or loss during other circumstances like mourning, the going away of a family member who may not be back for some time, so separation, the loss of connection to land or a place where you'd go and spend time, changes to the environment or to places, or sorrow for what's happened through the circumstances of trauma. The experience of grief and loss is extended through what we understand as sorry business as Aboriginal people. So sorrow and grieving can also be felt right now for the loss of security and the freedoms we currently don't have that took many years for our people to share in with the rest of Australia. Many Aboriginal communities face geographical isolation and significantly more restrictions than other communities, and this has a great impact for people's sense of well-being. Even though many do understand it is for good, it rings of historical challenges and punitive actions. Many people are worried or feel increased stress about what is happening with their finances, with their family's health. Many feel concerned about what's happening in their homes or in the homes of their loved ones who they can't see or be with right now. Many are worried about what this pandemic can do to us, especially to our elders and our most vulnerable. And this is a time that can trigger additional stress and a sense of loss and raise feelings of past grief also. It is in this time it's necessary for us to protect our people from COVID-19. This pandemic could have such a devastating impact for Aboriginal people, leaving us facing times of extreme grief and loss on a widespread scale. So how can we support our communities in this time? There's been tremendous response from government and non-government sectors to support people in their homes with the challenges that we face in this pandemic. Many services have stepped up to being accessible in new ways, such as telehealth and other avenues. Unfortunately, with the restrictions, many services are no longer able to do face-to-face service delivery. The more we can stay connected with individuals, families and communities in these challenging times, the more supported people will feel to reach out. Accessibility to services is still very important. There have been some amazing resources developed, and Kylie did make mention of a number of those in New South Wales and particularly in some of the other states like Queensland. And many of these resources are relative to sorry business. For our services and communities to have these resources readily available is one tool that we can suggest is quite easily able to be circulated. In this time, all of our services would, from our perspective, need to have a heightened sense of the impacts of sorry business in the context of COVID-19, and how our usual ways of grieving and mourning and even healing have been disrupted. This may mean our communities might need additional support for health and well-being, Many services are having conversations with each other and with communities about how support might be given safely and in a responsive manner when it's needed. Our core business may consider adapting somewhat to the context of responding to grieving communities, and that's okay. It's actually culturally responsive. Awareness of what other services are doing is also really important, so we know where local supports might be sought if we're not able to respond in our own capacity. So collaboration is more effective than working alone or siloed. Where we're able to have direct interaction with individuals and families experiencing loss or grief, we may be able to speak with them early about different ways or suggestions around some of the details around holding a service for burial or funerals, or to support a family member who they're not able to visit. We may have some suggestions that a grieving person might not have considered, given how overwhelmed they might feel with what's happening. It's important that we don't add to overwhelm, but alleviate the stress if we can. We may be able to assess if families or individuals might not be managing so well and be in need of additional support or response. Maintaining connections with family is vital for our people to move through grief and loss. Grief and loss are complex emotions, and we all respond in different ways to grief. Talk to people about who they're able to talk and connect with about what's happening, or even who they might be able to spend time with, whether that be over the phone or FaceTime or WhatsApp. Talking to people about how they are managing with sleeping and with eating and with work or caring for their children. It's important. It might be important to understand how they're managing, to be able to assess how and where they need support. There are some really creative solutions that have come out from many communities, and I agree with Kelvin that that's one of the strengths of our culture. How creative and how we really rise to the challenges quite often, more often than not. And there's been some really creative solutions to how we respond in the face of not being able to have sorry business, how it ought to be responded to. So some of the ideas in communities that we've become aware of are creating or using social media pages as a strategy to keep communication open with family and community members, collating slideshows and picture stories that can be shared with families to view at home or on social media. Messages have been sent to be shared at the funeral from each family member or individual to read out at funerals and to share. Recordings have been made of messages or songs also to be played at the funerals or given to families. In small communities, families have stood in their driveways as the funeral car has driven past the homes, singing a song or holding up messages as a funeral car passes by, holding the loved one that's their very last journey through those streets. At some graveside funerals, there's been a show of respect by families being parked and staying in their vehicles outside of the cemetery. This may need to be discussed with local governance to permit it on passionate grounds, but it's been something that's occurred in some places. Many families with assistance from funeral companies have been able to live stream funerals or make arrangements for memorial services following COVID as part of a service. And some families are deciding that a headstone unveiling will be where they have a proper funeral service. I'm sure there's many other solutions and ideas that can be shared. In the midst of this, it's really important that we, particularly as Aboriginal workers working in this space, take care of ourselves and of each other. Many of us are part of the communities and families that are being impacted by loss and grief in this COVID context, and we ourselves are feeling the additional weight of what this pandemic brings to us, our families and communities and our workplaces. Words such as compassion fatigue, burnout and vicarious trauma might be terms that we use for this experience. So I just really want to take the opportunity to say it's important that we ensure we're able to seek support and relief, the relief that we need to be able to keep going, to keep working and keep supporting the most vulnerable people in our communities, keep talking to each other and supporting each other, to keep supporting our mob. And thank you for allowing me to talk with you tonight.
Right, thanks, Susan. Firstly, my name is Matt Shimoga. I'm the Senior Clinical Nurse at the Wobble Medical Centre here in Newcastle. I'd like to acknowledge the Wobble people for whose land we meet on tonight and pay my respects to elders past and present. I've been asked to just give a brief overview of what the Medical Centre is doing at this point in time with the ever-changing landscape due to COVID-19. Our big push at the moment is obviously our flu clinics, which we're holding at three of our 4 clinics at Hamilton, Raymond Terrace and our Maitland Clinic, which will be tomorrow. We've also done a successful flu clinic up at Karua as well. And we are also doing home visits for our elders and those that are unable to get into any of those clinics. We're going to their homes to do the flu shots for there. We're also doing mobile testing. We'll be launching into that very shortly. Clinicians, Aboriginal health workers will be undertaking swab training on Thursday coming up to ready us to go into the communities when needed to swab anyone that needs to be done. We're also looking at opening our respiratory clinic at our new Pembury Road clinic at Cardiff. Once that's up and running, we will then look at running a respiratory clinic there. Firstly, if a patient rings up with signs and symptoms of COVID-19, they will talk to a GP who will then refer them out to the clinic at Cardiff, who will then obviously be examined once they're out there. In terms of telehealth, it's obviously been a challenge for all those involved. It's something new, it's ever changing, and the community as a whole has seemed to embrace that quite well. Obviously, their needs are still being met. In terms of scripts, they still get to talk to a GP. The feedback that we're getting from community is basically they don't want to come in either. They rather stay home, stay isolated and not run the risk of coming into contact with COVID-19. If a GP does feel the need to examine a patient, we do allot a certain amount of time of an afternoon for that GP to bring that patient into the clinic to do a physical examination of that patient after the telehealth consult earlier that day. Rightio. Dr. Kat?
I've only got one hand here. Handheld mic. Thank you.
You hold that.
Oh, thank you. So, thank you so much. It's an absolute privilege to be up here with all of these amazing speakers. So I won't take too much time, but I just wanted to address a few questions on the Slido that have come through just relating to a couple of technical questions. So there was one about sewage testing. It's a great question, and I think that was mentioned in maybe a RACGP communication. it's definitely been used internationally, and it's been good at detecting when there's, you know, virus, I suppose, in areas where they haven't necessarily picked it up in the population. I guess our situation in Australia is a little bit different in that, you know, as I said before, we're pretty confident in our testing rates, that we're, I think some figures were published about, we think that we're getting, you know, around 92% of all the cases that are out there, which is actually quite a good effort. So we don't have any knowledge of plans to do testing of sewage or wastewater in the H&E area, but we'll certainly let you know if anything comes up about that. So nothing at this stage. There was also a question about BCG vaccine. So this is the tuberculosis vaccine, which some people might have had the maybe unpleasant experience of having had as kids, or in some communities have gotten it as well. So there's been a lot of excitement about, I mean, unfortunately it's not a particularly great vaccine against tuberculosis, TB, but there's been a lot of interest in various previous years on the non-BCG or non-TB effects of BCG vaccine. So I think that is actually being looked into in the UK, I believe, as a subject of research. There's still not a lot known in the space, and I don't think there's any active trials that are happening here, so we're not sure of the relevance of that for people in Aboriginal communities. But yeah, so watch this space. There's a question, about testing, so false negative and false positive rates. So this is when, you know, someone has the disease and then they get swabbed and the test comes back negative. So what's the chance of that happening? Or the other way is if somebody doesn't have the disease and then they get a test and then that test comes back positive. So they're wrongly told that it's a false alarm. They've told that they got the disease, but they don't. So look, there's a whole bunch of tests out there. I guess the first thing I'd say is that the point of care or the rapid tests that are being talked about, unfortunately, the performance of them is pretty poor, particularly the ones that are based on blood tests. So we don't recommend those at all for trying to pick up people that have the disease. But in terms of the tests that are being done at the labs, that's the swab test that's being done through, you know, the screening clinics, through the hospitals, through the pathology providers. We think that that's a pretty good test, really. There's a lot of things that will affect that test. So, for example, you know, everything from how kind of hard the person takes a swab, how much material they get on the swab. So, I mean, from personal experience, I've had one, it's pretty uncomfortable, but that's how it's meant to be. There's some pathology companies that are offering self-swabbing, and so there's concern that people, if they don't kind of go deep enough or hard enough, that they're maybe going to get a false negative result there. There's also some situations depending on where you're up to in the stage of the disease. So, you know, early on in the disease, a swab that's negative is thought to be pretty reliable, that, you know, if you got symptoms and the test comes back negative, it's fairly reliable that it's probably not there. But, you know, later on in the disease, I guess it's less reliable because it's trying to pick up any virus that's there. And also, like we spoke about, using swabs to try and clear people or release them from isolation has thrown up a few problems, because sometimes the swabs can actually stay positive for a long time, which is possibly just picking up dead bits of virus and not actually someone's posing an infectious risk to the community. So that's why we're really encouraging you to stick with the national and international guidance around, for most people, you know, you don't need to swab them after they've been diagnosed to release them from isolation, and the public health unit will help with those decisions. So I think that's that one, and I don't think there was anything else specific for me, but happy to take anything else if there's other technical questions, and I'll hand back to the panel. Thank you.
Here from the studio of PHN Land. I have a couple of hard-hitting questions for you guys. Matty, I'm going to put you on the spot right now.
Right.
It's what we're sort of talking about. Is Awabakal conducting Zoom and Skype consults with clients? If so, and how much is being utilised? The community really embracing and adapting to that way?
Yeah, so we do have, we did purchase, or the AMS did purchase iPads as well, so where clients can photograph, lumps, bumps, moles, that sort of thing that they might want to get checked, the doctors send through. They also, we've also purchased some Zoom telecommunicate, TV monitors where Zoom will be utilised. So we're in the process of setting all that up as well for that to be utilised for the patients.
Probably a question for you, Kylie, seeing you work in the rural and remote. How are people overcoming issues on IT access and adequate resources for our mob?
As I said, a lot of the aim quickest off the mark to get resources designed and developed by their own organisations. And then, along came the ones from the bigger organisations, and then eventually the ministry. There are still some IT challenges even within the health service. We don't even have Wi-Fi available in a lot of our hospitals at the moment. So when our family members are going into hospital and we're saying, hey, FaceTime each other and connect in these ways, you can't have anybody visit you while you're in, and you can't bring your family with you, and you're stuck for 4 hours at ED, we can't even, have access to Wi-Fi. So we have challenges for our staff still, not accessing Skype and being able to use Skype and Zoom. All that technology is being rolled out. So if we have this in our organisations, then we're definitely going to see challenges for IT in our communities. Some of our mobs, might have a mobile phone, but it might not have data. We really have to think about how, when we start seeing, some more cases in community, people who don't have mobile phones, and how we could then connect with them and keep in touch with them every day. We're already thinking about, do we just, organise a couple of cheap mobile phones so we can contact them each day? Because these are real challenges in our communities. We can't assume that everybody has a mobile phone. We can't assume that there's mobile service wherever we go. In a lot of our communities, we don't have, good coverage at all. People need a couple of different phones, usually a, Optus and a Telstra phone, because of the patchy service, depending on what they're doing. It's probably lots of challenges still. The further out you go, as you know, Tony.
Yeah, and there was a question for you, Calvin, that I showed you before about people with prepaid phones.
Yeah, I think similar to that, it really depends on how inventive you are in getting Wi-Fi access. It can be by phone, and I think the nice way to overcome that is that rather than you call in, there's some checkpoint, and then the health facility calls you, so you're not using your credit, but also using Wi-Fi where you can get access to Wi-Fi. And you can be quite inventive with that. You can go to a car park of many institutions that have free Wi-Fi and have a conversation around there. I think the only caveat I say to that, which we're trying to work out the best way to go about it, is making sure that the consultation is still confidential and private. And so making sure one of the new platforms I'm using actually encrypts it on both ends. So if you use a public Wi-Fi, it's still encrypted, so it's very safe to use. I'm very happy with that. So some of those things we're starting to iron out, but that's a very important point.
Some of the really good, ways of service delivery now are really making a big difference for our mobs. It's, as I said, it's nothing that's not been suggested in the past by our communities, a more responsive health service, one that, doesn't just do service delivery from 8:30 to 5, one that's just not weekdays, but one that's actually more responsive to community need, and one that also looks to break down barriers and challenges. Like now, it's amazing how quickly we've been able to change the service and to change the way we do business, because COVID's really so far mainly affected our working class and our rich people and those who are already fairly privileged. We really want to see these things broken down for our mobs now. These are the systems and the things we can change to suit our families all the time. Like a lot of the stuff, we definitely want to go back to face-to-face, but when all this is over, I don't want to hear any GPs, or I don't want to hear any chemists, or other places start saying, oh no, we can't do it like that, and all of a sudden we have all these barriers to access, we have all of these challenges, and we're expecting people to jump on 3 buses to get to the hospital, and we're expecting them to bring the whole family in to get a flu shot, and to drag our elders around in the middle of winter to get a flu shot. I really want to see a lot of our services, particularly our mainstream government services, and our health services and our other key services, you know, the way they're all responding now and working together and providing a service that suits those who need it the most and that suits those most vulnerable, and a service that actually, you know, it's not people who are hard to access, it's our crap system. You know, we know where they are, we can find them, but how hard are we working to get to those people? They're the things that really need to change, and IT doesn't do that a lot of the time. It's people power and having a workforce that's willing to go out and reach the people who need it the most.
Yep, thanks, Kylie. Calvin, seeing you work with little people, I wanted to ask you a question about any suggestions on how to provide education for kids in the community. Many don't seem to understand about isolating and are still walking the streets together. What would you say?
Yeah, it's really hard because I think kids are in that different position of certainly not appreciating it, but the disease process in kids is very different to what we're seeing in adults, and I think that's an important part. I think the hard thing for kids to understand, particularly our adolescent kids, is really the risk that they can pose to other community members by not isolating. And when it's not affecting you, I do understand the difficulty and they have in appreciating the importance of isolating. We still don't know how that vector is transferred and whether it's actually good in kids or not. We're not really sure about that. And so as a precaution, I think it's really nice to make sure we maintain that isolation and make sure we maintain that distance. Part of that process as well is obviously the education of parents, teachers and elders in the communities to really make sure that message gets through. Because if it is to be a vector and it means that one of our elders is harmed by this, then I don't think the kids would actually appreciate that in its full context until it actually happens, and it's too late then if it breaks out and spreads. And so I think all these scenarios we need to talk about and realise what could happen if we don't. And again, going back to the similar analogies overseas, such as Singapore, where they're having a second outbreak now. So we're really got to be on top of this and really be aware of this. And I think one of the things we keep coming down as a lecture to community, I think we really need to applaud community and the efforts that we've made so far to do such an amazing job and how quickly we've shut down. And I think a lot of our patients and our communities and our services were closed down before the mainstream services was, because we knew what risks that posed. So obviously the leadership within our communities is actually really solid and reaffirms to me the sensible nature in which we're delivering the healthcare to our community. So I think really honing on that. In terms of education, education's really hard. There's been some wonderful free access to a lot of educational resources across the country in terms of access, but again, Wi-Fi is an issue. But I guess I go back to thinking again a bit more laterally in terms of what we mean by education. And one of the most beautiful things about this isolation for me personally, and I think it's affected a lot of my family, is the amount of time I'm spending at home. And I'm probably as busy, if not busier from a work perspective, but I haven't been required to travel for conferences, for outreach clinics, for work purposes, which means there's a lot more time at home. And I think that home education around our culture, particularly when a lot of it is a oral history, storytelling. I was chatting about my nan the other night to my son, which is just a beautiful thing. He was asking all these questions about nan, about my great-grandparents, about some of the stuff they've gone through. And I think it's really nice for us to just reconnect with some of those bonds. And that's the biggest education you get. And we just don't have time in this fast world to actually sit down and have a yarn again. I think I'm really enjoying that part of it quite a lot.
I must say that's probably one of the things that I've liked about being locked down is FaceTime my granny and my children, having some fun laughs and all that type of stuff. So they've actually stood still for a while. I think that's the end of the session. There are a lot of people still. It's been really good seeing some conversations and people posting resources for other people that have asked for them. If I haven't, someone said, honestly, Dr. Kelvin Kong, you're a rock star. And I absolutely agree with that 110%. You are a rock star. And all the likes that Kylie's getting is just, yeah, I don't even know what the go is with that. But yeah, so there's a lot of people that posted links and stuff like that for further information. And if I haven't answered your question, I will actually write to you and answer those questions. So Just want to thank everyone for participating, and Kelvin, I really want to thank you for the short notice that I gave you.
Pleasure.
You're a superstar, and Kylie, you absolutely, yeah, and Susie out there too. But you gave a really, really good presentation from the heart and was really clear and easily to follow. So thanks. And thanks, Maddie.
Thank you.
You're the bomb.
Christy.
Oh, Christy. Shit, for people you can't see, she's standing jumping, doing star jumps in front of me here, saying, "What about me?" And Dr. Kat, as always, thanks very much. And JB, thanks for your update. And Kathryn Todd online as well. So thanks. And good night, everybody. Have a restful night. And hopefully see all your faces soon. Stay safe. Black and deadly.